Moving on to the much awaited quiz program, I request all the participants to come to the dais. Uh, at the outset, congratulations to all the winners for clear the prelims and advance to the final round. I would like you to get introduced. You are Team A. Okay. Can you introduce yourself?
I'm Osborne Benedict, second year general medicine, CMC Vellore.
Joseph Liaskar, final year postgraduate general medicine, CMC Vellore.
I'm John Roy, I'm a final year postgraduate CMC Vellore.
Narendran, second year postgraduate CMC Vellore.
I'm Monisha, second year postgraduate from Vellore Medical College.
Okay.
Abhishek, second year postgraduate, Vellore Medical College, General Surgery.
Oh, medicine and surgery combination. Both of the surgeons. Both of you are surgeons.
I'm Suprit from PS Medical College, Kuppam, second year general medicine.
I'm Shiva, second year postgraduate general medicine department, PS Kuppam.
Welcome all. So this quiz, it has 4 rounds. In the first 3 rounds, each one of you will get a chance to answer the question. 1 pass is allowed. So the team that answers the questions on the first chance will get the full points. If the team answers at the pass question, 2.5 marks, like half the mark will be avoided. Will be awarded. Okay. So in the final round, it will be bits on the rounds. So whoever presses the bell first will take a chance on the answer. Team A, this question is for you. So a 23-year-old has come for odenophagia. She has been doing well, otherwise she had undergone recent master health screening, it was normal. She only had chickenpox as a child and she is only on treatment for acne and is using doxycycline. And she has a history of esophageal cancer in the grandfather who died at the age of 75 years. And she's been avoiding eating because of the pain. What would be the likely cause in this patient? The options are esophageal growth, esophagitis, herpes simplex virus esophagitis, esophageal candidiasis, prostocoid web.
Esophagitis.
That's right. Team A has answered correctly. Esophagitis is a common scenario used with certain medications, especially doxycycline, clindamycin, bisphosphonates, and also the newer anticoagulant dabigatran. That should also be borne in mind. Okay, the next question is to Team B. So, which of the following extraintestinal manifestations of IBD typically worsens with exacerbation of disease activity? Ankylosing spondylitis, arthritis, nephrolithiasis, PSC and uveitis.
Uveitis.
No, the correct answer, sorry. Who pressed, I'm sorry? Okay.
Ankylosing spondylitis.
No, that's it. That's only 1 pass is allowed. But for fun, someone knows the answer can answer. There's no points. No, the correct answer is arthritis. Peripheral arthritis does not parallel with the disease activity. Yeah. It typically worsens with the disease activity, whereas the rest, they do not parallel with the disease activity. So, no points in this round. Let's move to the third question. To Team C, which of the following is more likely to cause a pneumoretroperitoneum rather than a pneumoperitoneum? ERCP and its complications, gastric perforation due to a peptic ulcer disease, laparoscopic appendectomy, sigmoid diverticular perforation and small bowel infarction. Team C?
ERCP.
That's right. Would you say why?
In the second part of the duodenum is retroperitoneum.
That's right. So the rest of the organs mentioned here are intraperitoneal. That's correct. Team C has got it correct. The next question is to Team D. A 33-year-old male has come with chronic abdominal pain. The CT abdomen shows calcification in the pancreatic parenchyma. There is a ductal stricture and there are calculi in the pancreatic duct as well. My question is, which of the following least alleviates pain here? Surgery, pancreatic enzyme replacement therapy, opioid analgesics, endoscopic therapy.
Pancreatic enzyme replacement therapy.
That's correct. So the rest of the options do alleviate pain. Surgery, right now it's early indication, there is an early indication for surgery in patients with chronic pancreatitis. Opioid analgesics do alleviate pain, but it's not the preferred option. And endoscopic therapy is also a proven modality of treatment in patients with chronic pancreatitis, especially with ductal obstruction. Okay, the next question will be to team A. So, which of the following is an indication for a patient who is asymptomatic and has come for an opinion regarding cholecystectomy? 2 gallbladder polyps of varying size, maximum is 5 mm. Gallbladder polyp 8 mm and has been stable for over a year. And 3 gallbladder calculi of varying size in an asymptomatic person, or the combination of gallbladder polyps and calculi.
GB polyp and calculus.
That's correct. So the rest of the things, they are not an indication for cholecystectomy. I think team A has answered it correctly. Let's move to the next team. After a month-long hospitalization for complicated UTI and AK. Otherwise, she had been previously well. Which of the following is least helpful to diagnose pseudomembranous colitis? Routine stool culture, stool GDH by enzyme immunoassay, stool for toxin A and toxin B PCR, colonoscopy, and the CT abdomen. We all know it's a constellation of tests.
ECT abdomen.
Team A. That's right. Can you say why? It can grow Clostridium difficile, but we need to know the toxigenic strains. So a toxigenic culture should be done. Anaerobic culture followed by toxin testing has to be done. So the routine stool culture that we order may not be helpful. The rest of the tests in combination are used to diagnose C. difficile infection. CT abdomen, though not specific, it will also show some signs of edema in the colon, which we call the classic accordion sign. So it may be helpful. 2.5 marks. Team C 0 and team A gets 2.5 marks. The next question is for team D. So which of the following is considered a primary determinant of suitability of resection when evaluating a patient with colorectal cancer and hepatic metastasis? So number of tumors, the size of the metastatic tumors, the predicted volume of hepatic remnant, or prior therapy. Team D.
Number of metastatic.
Pass. Size? No. That's right, but you'll not get any points though. You are right. The predicted volume of functional liver remnant, that determines the metastatectomy. So those with healthy livers, 20% is acceptable of FLR. Those with prior exposure to chemotherapeutic agents that were hepatotoxic, at least 30%. Those with cirrhosis and all, 40 to 50% FLR should be done. If that can be spared, then metastatectomy can be done. Okay. So this brings the end of the first round. So the second round will be 2 questions will be asked. Each carries equal marks. So this also, I think we'll skip the pass in this. So there's no pass here. Okay, we'll just skip the pass here. So team A. Okay, team A is leading right now. Okay, so the team A, I think they already figured the answer. Identify the syndrome though.
Peutz-Jeghers perioral melanosis.
Yeah, that's correct. Peutz-Jeghers syndrome. So characterized by hyperpigmentation in the oral mucosa. So the question is, so as you rightly diagnosed, this patient has Peutz-Jeghers syndrome and is presented with recurrent abdominal pain and has intersusception on the CT. So which of the following would not be necessary for this patient? Gastroscopy and colonoscopy, screening for non-GI cancers, genetic testing, and prophylactic colectomy.
For prophylactic.
That's correct. That's correct. Team A has got it correct. Prophylactic colectomy is not indicated in patients with PJS, but rather it's advised in patients for those who have FAP or Lynch syndrome, Though they are at an increased risk for GI cancers, colectomy is not necessary as a prophylactic measure. Team A has got both the parts correct. 5 points totally. So now team B. So know what this is.
Asterixis.
Yeah, okay, asterixis, they've identified it correctly. So which of the following is not a predisposing factor for this condition? TIPS, EVL, repeated parasiticus, constipation, GI bleeding.
EVL.
That's correct. So I think throughout the lecture we were learning about the complications and the predisposing factors for HE. I think you got it pretty much right. So team B full points. Team C. So what is this and why does this present? That's correct. Can you answer into the mic please?
Rousing sign.
Okay, and why does it happen?
Acute appendicitis where there is a compression over the left iliac fossa due to peritoneal movement.
Correct.
Will cause an inflammation.
Okay, the inflamed peritoneum when it moves, it causes pain. That's right. So, but the question here is, you order a CT scan and find appendiceal inflammation with an appendicolith. There is no abscess or perforation and the family wants to try antibiotics first. Which of the following is true regarding the management of appendicitis? Antibiotics are inferior to surgery. Presence of appendicolith increases complications. Surgery should never be delayed. The likelihood of recurrent appendicitis after antibiotic therapy may be up to 90%. All these are from the CODA trial. Surgeons in deep thought.
Surgery should never be delayed less than 12 hours.
No, surgery can be delayed. If there is an uncomplicated appendicitis, surgery can be delayed. It need not be taken less than 12 hours. The presence of appendicolith though increases the risk of complications. That is the correct answer. Antibiotics are non-inferior to surgery and the likelihood of recurrent appendicitis after antibiotic therapy, it's not 90%, but it is around 30 to 40%, maybe up to even 50%. Yes, 2.5. So team D. So identify this sign. Now what is it called? Do you want to try again? Yeah, that's right. Great Turner sign. So it's seen in acute necrotizing pancreatitis with hemorrhage. Okay. So the question here is, which of the following is true in managing patients with pancreatitis? Prophylactic antibiotics prevent complications. Aggressive hydration improves outcomes. Lunastatin has strong evidence in reducing inflammation. Lactated ringer is the fluid of choice. That's correct. We've answered both parts correctly. So that brings that finishes the second round. Okay. So team A, team B and followed by team D. Okay. So let's move to the next round. Story in pictures. So mostly it will be pictures. You'll have to connect the pictures and find the diagnosis. Team A, it will be your turn first. So here's a man with painful secretory diarrhea and that's an upper GI gastroscopy picture. And to the right there is an imaging finding. Will you be able to tell the diagnosis?
Carcinoid tumor.
Okay.
Dottype is showing uptake.
Specifically, like, do you want to name what you...
Gastrochromafin tumors. Gastrinomas.
Yes, it's a gastrinoma, you're right. So here's a man with painful secretory diarrhea because of high gastrin. He has multiple ulcerations. It can be present in the stomach, even the esophagus, even in the duodenum up to the jejunum it can be present, and it's secretory in type. Meaning the patient, even when he fasts, he is going to have diarrhea. And for those patients, we do this somatostatin receptor study which is a nuclear imaging, which shows an uptake in the pancreas, probably with a mets in the liver. That's right. You got it correctly. Very good. So, team B, they got the full point. Yeah. The next question is for team B. Here's a young lady. She has presented with ascites, and the ascites of high exudative type, high protein low sag ascites, and there is slightly elevated CA125. There are a few cysts in the ovaries.
Those are showing perihepatic adhesions. This Fitzhugh-Curtis syndrome.
Okay. Just look at the right side picture also and tell a diagnosis thereafter. Fitzhugh-Curtis is not a bad choice. It's a
Could be a signet cell carcinoma.
okay. I think we should stop here.
It's Leak syndrome.
No, it's not Leak syndrome. There were all just the distractions here that elevated CA125 and all. It's a classic picture of peritoneal tuberculosis. So the nodules in the peritoneum and the fibrinous adhesions. And here to the right you're seeing granulomas surrounded by fat, peritoneal fat. So it's a classical TB peritonitis, laparoscopic picture and the HP. So this is a granuloma, caseating granuloma. So no points. Okay, the next question is to team C. Okay, this is going to be difficult, I guess. So, here's a patient who has an echo done for fever of unknown cause. So, then there is a blood culture that has been done. And then for some reason the patient has undergone a colonoscopy. The question is, okay. So probably I'll give some clues here because it's a little difficult. This patient has infective endocarditis. There are vegetations here under the mitral valve here. So there is a blood culture being taken. So clearly there is a link between the heart and the colon here. Okay. Do you want to give up? Okay, that's fine. There are no points, but someone can answer. I think team B.
This is a case of colon cancer associated with Streptococcus gallolyticus.
That's right. That's right. That's right. It is believed that initially they thought this colon, Streptococcus gallolyticus or Streptococcus bovis, it's a natural pathogen in the colon. So previously it was thought like once the tumor breaches, the organism enters the bloodstream. But the more recent hypothesis is bacterial translocation that results in endocarditis. So any patient with endocarditis who is growing Streptococcus bovis, and there are other organisms also that have been implicated, but commonly Streptococcus bovis, should undergo a colonoscopy to rule out a colon malignancy. No points. But good. So the next question to team D. So here's a patient with painful skin lesions, erythematous shiny nodules on the leg, shin, and then there is arthritis clearly, and on the CT there is pancreatitis. It's not erythema nodosum per se. It has a name. It's a syndrome. It's basically all the pictures put together the syndrome. I think we'll give up. Anyone knows the answer? Okay. IgG4, no. IgG4 doesn't present like acute pancreatitis. So this is a case of pancreatitis, panniculitis, polyarthritis syndrome, PPP syndrome. Typically occurs when it is believed because of fistulization between the pancreatic collection or pancreas into the mesenteric flow, resulting in release of trypsin and other pancreatic enzyme, thereby leading to fat necrosis in distant organs. So on the thing is, these patients need not present with features of pancreatitis. They may present with skin lesions or end up in the rheumatology department for arthritis. So also it can happen in patients with pancreatic adenocarcinoma as well. So no points to anyone here. Okay. So for 3 rounds are over. Let's move to the final round here. Tie, team B and D. So I think we'll have a tiebreaker round, I guess. So dips on this round. So whoever presses the bell first will get to answer the question. I think no passes will be there. Whoever presses has to answer. Okay? Team B.
Accordion sign pseudointramus colitis. Concertina sign.
No, take a look at the picture.
Jejunization of the ileum.
Okay, we'll allow one pass because it's a little difficult. Only one pass. Both of them got it wrong though.
Ischemic colitis.
No, it is ischemic colitis. See, there is something happening here. No more points for anyone, but there is something happening here, here. So there is something here. It's a gallstone ileus causing small bowel obstruction. So this is classically called the what triad? Wriggler's triad. The presence of small bowel obstruction, pneumobilia and ectopic gallstone. It's Wriggler's triad. Okay. For the next for the coming images, take some time and then press the bell. Okay. Team A did it.
Volvulus.
I think team A got it. Okay. So what would be the treatment options? Now you've got the answers. It's hemodynamically stable and hemodynamically unstable.
Unstable emergency contractile. Stable and NG. Platus tube.
Okay. Some decompression. Platus tube is one. There is endoscopic decompression. That is also possible. Okay. Team A gets 5 points. Okay. The next image. So it's a video. I can play it again. So this is a patient with CLD. I'll play it again. Team B.
Portopulmonary hypertension.
No. No, both of you got it wrong. But you are close. It was hepatopulmonary syndrome. Portopulmonary hypertension, we measure pulmonary arterial pressure. So this is to look for intrapulmonary shunts. So this is a contrast. Sorry. So this was a bubble contrast echo or a agitated saline test. So typically the saline was So if you look closely, when the saline appears in the right side, after 3 beats, like typically after the 5 beats, there is saline air bubbles occurring in the left atrium, meaning it's intrapulmonary shunt and not an intracardiac shunt. If it were an intracardiac shunt, it would be within the first 3 beats. Okay. Let's go to the next one. Team A. Let me give some clue. I'll just give one clue. You can press the bell again. So this is a patient with pancreatitis who has come with a GI bleed. That is the endoscopic picture, and later he was taken for an angio. Team D. Okay, that's a possibility. No, but that's not right. I think team C, press the buzzer again. Second. That's right. And what is this called on the left? Bleeding from the ampulla in a patient with pancreatitis. History of pancreatitis. Okay. Anyone else wants to answer this?
Hemosuppress.
Pancreatitis, yes. And what is being done here? And what is?
I think it's a splenic artery pseudoaneurysm.
That's right. I think we'll award the points to team B here. 2.5. Okay. So see the procedure first and then press the bell at the end of the video. So, okay, this is an upper GI procedure. I think team B has pressed the bell.
Peroral endoscopic myotomy.
That's correct. So this is peroral endoscopic myotomy. The view is in the submucosal tunnel and the circular muscles are being cut here. So they've got the answer correct. It is POEM procedure. So next one will be, let me play. This is a patient who has undergone some cardiovascular surgery presenting with anemia.
Hate syndrome.
No, you lose the chance. See what's inside first. I said cardiovascular surgery. This is an upper GI scopy and you're seeing something inside. Like feces. Tracheoesophageal fistula in the duodenum. No. So I'll give another clue. This is a patient who had Lerish syndrome and he underwent aortofemoral bypass surgery. No, okay, it's a little bit difficult, I agree. So this is an aortofemoral graft which has eroded into the D3 because the graft sometimes if it is chronically infected and because of the pulsatile nature and the constant pressing on the duodenum, sometimes it can erode into the duodenum. And when it bleeds, it can be fatal. Sometimes there can be a heralding bleed which can be very silent and looks manageable, but this would lead to catastrophic events. Okay, this is a patient who is undergoing ERCP and now we are positioned at the papilla or the ampulla.
Intramucinous papillary process.
That's correct, very good. Why do you say so?
I can see the mucinous in the gelatinous.
That's correct. The mucin is exuding from a patulous major papilla. And what is this called? That's correct, fish eye sign, just like the eye of a fish. Not the class, people used to say it's fish mouth, it's actually fish eye. So fish eye sign. So IPMN can affect the head of the pancreas and this finding is not commonly found. It's a very rare sign, but if seen, it is a diagnostic sign. It's pathognomonic of IPMN and IPMN carries high malignant potential. Okay. So this is a lady who presents with rectal bleeding. She is a diabetic, she is a cardiovascular patient, she has coronary artery disease, she is on dual antiplatelet agents and in the past she has been treated for cervical cancer. Now she has come with rectal bleeding.
Radiation proctitis.
That's correct. Team B has got it correct. Radiation proctitis. What are you seeing here actually?
I'm seeing angiodysplastic vessels. It's a sequelae of long radiation.
Yeah, prolonged radiation can damage the arterioles there, resulting in fibrosis, vascular thrombi and hyalinization. And this can lead to telangiectasia formation. They are prone to bleed. And how are they treated?
APCs.
APCs. That's correct. Team B answered everything correctly. Yes. Okay.
Melanosis coli.
Very good. So, what causes this?
Senna.
Senna. What in Senna?
It's anthraquinone.
Anthraquinone derivatives. Are they at a risk for colon cancer?
No, it's benign.
That's correct. Though it's benign, there is a slight predisposition for adenomas, but otherwise it's a harmless condition. I think pretty much Team B ate this round. So I congratulate everyone. Everyone did very well. So the third place, shall I announce? Shall I announce? No? Okay. The third place goes to Team D. Can we have a round of applause for them? And the second place goes to Team A. And the first place goes to Team B. I think the surgeons were a little at a disadvantage because of the medical questions. Okay. Congratulations everyone. I hope we all had learned something from this session.